that when you lie down on your back, the spinal cord goes closer to the lead and you feel more stimulation. While when you sit or bend forward, the spinal cord goes away and you feel less stimulation. When you cough, because of the expansion, the stimulation is pretty high. So accelerometer was put in the IPG. So the IPG knows if the patient is standing upright or horizontal, and takes a little bit more when you program it. You got to program it in 3 different positions, but it's very, very doable. And the 6 weeks crossover study showed better and sustained pain relief. This study was done by Michael Nagy and Michael Stanton Hicks. And this is how the amplitude changes. So in open loop SCS, nothing changes if you move the position. But in closed loop stimulation or position responsive stimulation, the amplitude goes down when there is increased pressure inside the spinal cord. There is actual open loop stimulator also available for spinal cord stimulation, which is recently come in market. This is a ECAP, Evoke Compound Action Potentials. Evoke Compound Action Potentials are one of the biomarkers for the pain. So they sense the ECAPs from the spinal cord, and if they notice a train of ECAPs, they will deliver the stimulation. Otherwise, they will not deliver the stimulation. And this is just one of the things that out of these multiple contacts, some are selected for sensing, and then some are selected for delivering the stimulation. Normally, you guard the sensing contact with the stimulating contacts. This is the stimulation parameters they are given for different. Normally, there is a little bit of baseline stimulation, but when the ECAP events come in a train, the stimulation goes high up. Why can't we use the stimulation on external parameters to close the loop? So this was one of our projects at WVU, where we use heart rate variability, cognitive analysis, sleep, functionality, and made that into an app. And that app will deliver the stimulation. So app controls the spinal cord stimulator. And when these started going completely out of range, it delivered the stimulation. So you can have not biomarkers, but external markers, the surrogate markers, which can make the stimulation start. So this was one of our studies, and in this we use TMS, TDCS, SCS, all those things for closing the loop of the stimulation. We use this in addiction more than pain, but pain and addiction are like cousin brothers. So in addiction, we could sense that when the HRV changes, the relapse is imminent to happen. So we used to start stimulation. It was DBS, nucleus accumbens. Same thing in pain. Some of our pain patients, we kept them on demand stimulation based on the HRV data in their app. And the HRV changes, then only the app controls the battery to deliver the stimulation. So you can close the loop in various ways. It doesn't have to be extremely complex lab-based way. You can just do it on external surrogate parameters as well. But I think closed loop stimulation is for future, like body heat powered batteries are for future. I think these are sustainable technologies. In a country like ours, if you have a stimulator which will last for the rest of your life, people will always go for it, then change it every 15 years. Thank you.
Thank you very much. That was an excellent talk. I think you're absolutely right. There's no biomarker for pain. All of these are surrogate markers, and although the ECAP-based system is there, It still is not a true closed loop. That's why they call it a smart loop rather than a closed loop.
Right.
You're right. There could be some external cues that can be taken to close the loop, but as of now, we don't have a true closed loop in pain.
Right.
Any questions?
Excellent talk.
Thank you.
It's an excellent talk, Milind. So, as far as I know, in VNS, only the higher model offers some kind of closed loop mechanism by tagging it with the heart rate.
Yeah.
Right.
So, you have atrial tachycardia,
Yeah.
so it becomes a closed loop.
Yeah.
So, that may not work out for a closed loop for pain. Tachycardia is more commonly associated with epilepsy than pain.
Right. Right.
And if I'm right, I have done some literature review. I don't have experience of VNS in pain, but all the studies of VNS in pain is more for non-invasive VNS. So, are you aware of any invasive VNS which has been done for pain?
Oh, Cyberonics and now Levanoma, they will put in VNS for even baldness at some point. Not to criticize a company.
But are the studies done invasive VNS?
No. I don't think there are any invasive VNS studies. I mean, the first VNS I did was in Arizona with Sherman. That was the first trial. That was in 1996 or 97. That's when it got approved. Then it got approved for depression, and we did a bunch of those, like 70 of those. And then the insurance company stopped paying for it. Then I did it for right heart failure. Then I done VNS for obesity. And we done VNS for a lot of other things. But I don't really see the physiological basis for that. I mean, antidromic stimulation, the vagal pathway, parasympathetic pathway is completely different than medial and lateral sensory pain pathways. So, medial sensory pain pathways goes to locus coeruleus and all those things. And lateral pain pathways, we all know the spinothalamic tracts. Even the associative pain areas like anterior cingulate or prefrontal cortex, all these things are not in vagal distribution at all. So maybe hypothalamic neuromodulation it does, but no, I haven't seen a trial for VNS for pain. Thank you. So this is Ramesh came with his talk, evidence-based neuromodulation and outcomes in pain neuromodulation. Now, as far as the evidence is concerned, in spinal cord stimulation, there is some evidence. In DBS for pain, there is no class 1, class 2 or class 3 or any kind of evidence. And other interventions that we do in pain has very little evidence. So we'll talk about other procedures later on when my talks are there. But this is primarily on spinal cord stimulation. These are my COIs. So how many of you treat chronic pain? Okay, a lot of you. So first thing you need to remember that acute pain is a symptom. Chronic pain is a disease. And when you treat chronic pain, you are basically doing a job of a psychotherapist, a psychiatrist, a compassionate listener, and a doctor. So you have to be as much as a psychiatrist, because one of my clinic in the week used to be chronic pain clinic, and I used to be mentally exhausted. I used to see only 8 or 9 patients, but used to be mentally exhausted. At the end of that 8, 9 patients, you had to listen and listen and listen. And that's why those patients will get good benefit. So William Osler once said that sometimes you cannot treat the disease in a person. You have to treat the person in the disease. And this is when I met Ron Tasker. Ron Tasker is a big name in pain from Toronto. And I asked him about this. How did you select the pain patients? And what he said, that everyone who has pain more than 6 months is going to be crazy. You cannot be not crazy if you have continuous pain for 6 months. The idea of whatever you do before is to find out if he was crazy to begin with, and that's why he got the pain, or he became crazy because of the pain. And once you are able to differentiate in that, your outcomes will be much, much better. So I think that's the whole trick in treating the chronic pain patients. Another very, very nice sentence which early in my practice of chronic pain, someone told me was a statement by Spinoza. Pain is a localized form of sorrow. So whatever sorrow you have in your life, that kind of gets down to a part of the body, and that creates the chronic pain. Apart from all the neurophysiological things that happens. So the key points when you treating a chronic pain patient is do not try to cure the pain. Pain will not get cured. Just make it tolerable. Just tell the patients beforehand that it will reduce by 50%. Benefits are the same, lower the risk. So if I do a DBS, I get a 50% benefit. If I do a PNS, I get a 50% benefit. If I do a TMS, I get a 50% benefit. So choose your battles, choose your patients where you think you can get away with a minimally invasive or non-invasive procedure, go for that. And then more than that, know your patient. Find out if there are any other reasons why he is having chronic pain. Are there any social circumstances that need to be dealt with? All those things you got to take into considerations. Type of pain is very important. The more widespread the pain is, the less it will respond. Neuropathic pain will respond the best. The nociceptive pain, musculoskeletal pain will also respond very good. Visceral pain will respond to some extent if it is coming from a specific source. I done DBS and spinal cord stimulators for pancreatic cancers, respond very well. I done DBS and PNS for non-specific abdominal pain, very, very unsatisfactory response. Find out if there is allodynia. Find out if there is sensory loss. That will decide which strategy you will take. Again, coming back to area of pain. The area of pain is smaller than 2 credit card size. That will respond best to your intervention. Whatever intervention you do. You do nerve blocks, you do peripheral nerve stimulation, you do spinal cord stimulation. Area that is in perfect dermatomal distribution. That will respond very well. Vague areas, midline areas, those areas will not respond very well to any kind of intervention. Neuropsychological examination is a must. Anyone who wants to practice functional neurosurgery has to have a full-time neuropsychologist, because every functional patient has to go through a neuropsychologist, whether it's movement disorder, whether it's pain, whether it's epilepsy. Obvious red flags are generalized pain, psychiatric problem. Subtle red flags are complete improvement during trial. I had patients put in a lead in this evening, go to see them for trial, and they say, I'm pain-free. And when people say that, I always think this person is going to come back after 3 months with pain, because you never get pain-free if you have pain for like 3 to 4 or 5 years. Pain will be reduced 80%, 90%, but never pain-free. And people who chase pain, that, oh, this part is better, but that part is not better. So those patients, those are the red flags you should think about. Also, the patients who come to your office and say, you are my last resort, or you are my God, those patients, be careful with those patients. They have a lot of somatic, psychosomatic involvement in their pain. And that's why these subtle flags you understand as you practice more in chronic pain. Expectations have to be set right. Things are not going to get cured. Things are going to get better. Life is going to be more tolerable. Insurance issues are not so much in India. This is just a trend of my practice in neuromodulation. This is an old slide from 2016. But as you could see, my PNS number went fairly high. SCS remained the same. DBS numbers went down. Motor cortex numbers almost stopped after 2016. But these three modalities, SCS, PNS, ITP, remained fairly high continuously throughout my career, because these are less invasive procedures. So remember, less invasive to more invasive. They have similar benefits. They have less risk. Rather than lesioning, go for DBS. Rather than motor cortex stimulation, go for PNS. Rather than DRES, go for PALMS. TMS or virtual reality are very good in the armamentarium of pain procedures. These are some of the pain procedures that we can talk about, the evidence-based, what evidence we have, but we don't have that much time. So I'm just going to stick to the spinal cord stimulation. And this is a very good paper. I think it comes from Mark Russo's group in Australia. They have Australia and New Zealand, they have given guidelines about and evidence about what evidence we have for spinal cord stimulation. And for neuropathic pain, there is a strong evidence as a primary indication. PSPS is a fancy name for failed back syndrome, persistent spinal pain syndrome. Nowadays, they use that like CRPS for RST. So PSPS, CRPS, peripheral neuropathy, post-surgical neuropathy, strong evidence, class 1 evidence also available for that. Nociplastic pain, not so much, but still patient selection is critical. Nociplastic is a new term in pain. Nociplastic is the centralized pain. What we used to call centralized pain syndrome, now they call nociplastic pain. Nociplastic pain and neuromuscular dysfunction, there is not much efficacy with SCS. You have to think about something else. Ischemic pain, there is good evidence, but it's all observational. PSPS supported by RCTs, long-term observational study. CRPS, again, there is RCT on this. They haven't covered it, but there is RCT on CRPS. And CRPS responds beautifully to neuromodulation. Peripheral neuropathy, there is RCT ongoing. I was part of it. It's a 12-year-old project. We've done about 60 or 70 till now, with very good results. So any kind of peripheral neuropathy, spinal cord stimulation is good. Peripheral vascular disease has actually been approved in Europe. It has got a C mark. So it helps in peripheral arterial disease. And angina also, it helps, but it's anecdotal evidence. Contraindications, what they have said, absolute contraindications is treat the primary pathology. So no spinal stenosis, active infections, coagulopathy, major psychiatric disorders, and that's why you have to, I would say even minor psychiatric disorders, unless you bring them under control, don't try spinal cord stimulation. Then they are also given where should we use what. So tonic SCS, high frequency SCS, burst SCS, closed loop tonic SCS. I'm not so much of a fan for this. I mean, I personally think if it is axial pain, high frequency and burst SCSs work better. It's appendicular pain, everything works the same way, whether it's high frequency. I mean, Girish might disagree with me, but I mean, when Neuro came, everyone started putting Neuro, and we saw the results were not very different. On the other hand, with the perceptible SCS, you know if your lead is in right place or not. So, recommendations, they're given recommendations. You need a specialist consultation, you need a patient caregiver education, you need a psychological evaluation, you need diagnostic imaging. Is there evidence that it works? Physiologically, this was our paper. I like to bring it up because it came on Neuromodulation front page, that we actually had shown that the spinal cord stimulation works not on spinal cord, but on the brain. So the bane of the pain is always in the brain. Always remember that wherever the pain, it's always in the brain. What we had shown is there is a decreased connectivity between the somatosensory cortex and the limbic cortex when optimum stimulation happens, and that gives you pain relief. So when the connectivity between somatosensory and limbic cortexes go down, you will get the pain relief. Just stimulation or inhibition of somatic sensory area will not cause any pain relief. So it's the affective pathway. That's the culprit in chronic pain. It's not the lateral pathway. Thank you very much.
Thank you very much for that excellent talk.
Thank you.
Any questions? Thank you very much. Thank you. Yeah.
What's your opinion about this pre-gabapentin, gabapentin? There's a huge rise of use of all these medicines. So, what do you think is your take for the treatment of chronic pain?
I give it very, very rarely. And especially if you have peripheral neuropathy or something that is lot of tingling, numbness involved, just for pain, I will not give it. I mean, my patients generally don't like it, but I won't give too much of medicine for chronic pain patient. We have a structured rehab, daycare rehabs. So we bring them there, we take them to the pool, we do psychotherapy, CBTs on them. We just give normal NSAIDs, non-steroidal anti-inflammatory. Sometimes tramadol type of things if there is acute exacerbation. We use lot of modalities, TENS, IFT and all that. Pregabalin or gabapentin I give only for patients with actual peripheral neuropathy. And I generally stop it after a month and a half, 2 months at the maximum.
The number needed to treat is very high with pregabalin and gabapentin to get one beneficial patient, but it dictates that you have to use the conventional medical management before you consider spinal cord stimulator. So we use it, but it's not very effective for most
It's not
patients.
very effective.
Yeah.
No.
But then using this gabapentin and all these neuropathic drugs before going ahead with the invasive procedure, is it recommended that we have to have this period of these drugs and then have some?
But the nice dictates that you have to try the conventional treatment before you put in an expensive device in. So we do try as a part of the multidisciplinary assessment.
So does it guide the treatment?
No, it doesn't guide the treatment. No.
Just one of the requirements you have to fulfill in American Pain Society's pyramid also, the comes before opioids, but after all the drug treatment that he's talking about. Thank you. Okay. So this is the first talk of this session, and I'm going to talk to you about deep brain stimulation for pain. I've been doing deep brain stimulation for a long time now, since 1998, and since 2001, exclusively only DBS and spinal cord stimulation. If you look at my numbers, I've done close to 3,000 plus DBS. Out of, if you look at DBS for pain, they are probably less than 100, maybe 60, 65. Something like that. So that can tell you the disparity between the DBS for sensory disorders and DBS for motor disorders. Modulation of pain, central neuromodulation, the modulation in the brain, you don't have to put a DBS. You can just give medication. They do the same thing. They do central neuromodulation. You can even meditate. We are writing a new book on theotherapy, the neuroexistential therapy and neurotheology, how God helps reduce aging and stress, but that's beyond the point. And then we can do invasive cranial procedures like DBS and spinal cord stimulation. We can do wearable cranial devices like Cephali, or the one we have here in India is pen band. We can do spinal cord stimulation and still cause central neuromodulation. Or we can do peripheral stimulation, like in occipital nerve stimulation, you can still stimulate the anterior cingulate. So brain intracranial neuromodulation is not always DBS, but we still are going to talk about DBS. And for DBS, what you need to understand is the main one of the landmark papers is by Jamanod. So Jamanod is from Switzerland, and he has been doing interventions in brain for pain for a long time with an absolutely excellent results. And his whole idea of chronic neurogenic pain being a result of thalamocortical dysrhythmia is what piqued the interest of people in putting in a DBS and breaking those thalamocortical dysrhythmias. And what's a thalamocortical dysrhythmia? When thalamus and cortex beats in unison. So what we used to do during pain DBS, we used to put two leads in the thalamus, and they were externalized and they were attached to monitors. And we also used to do scalp EEG, and we could see the coherence. I mean, the thalamus used to go at 4 hertz, and the cortex also used to go at 4 hertz. Cortical firing increases, the thalamic firing used to increase. So as if they are synchronized. That is called thalamocortical dysrhythmia. Actually, it's a wrong name. It's a thalamocortical synchronization, but it's called TCD. And that what causes all the positive symptom neurological disorders. May it be chronic pain, may it be tremors, may it be psychiatric disorders, there is some degree of thalamocortical dysrhythmia. And Chavanos described this, and he actually found out the posterior limb or the descending limb of CL. Now, thalamic nuclei have hundreds of names. So for this pain, we will use the Morell's terminology, which is more appropriate. So VL is nucleus ventrolateralism. It's one of the intramedullary nucleus of thalamus. It's like a scimitar, and the posterior limb of the CL is where you generally want to attack for chronic pain. Now, this idea of thalamocortical dysrhythmia was further demonstrated by Rodolfo Linas when magnetoencephalography came. So he found out a MEG signature of thalamocortical dysrhythmia. This is my picture with him. This is me in last life with full head of hair. And that's Ali Razai, and that's Andre Machado, and that's Rodolfo Linas when he had come to Cleveland Clinic. So these are all the procedures for intracranial neuromodulation. We're not going to talk about others. We're not going to talk about this. We're just going to talk about DBS. So what are the targets for DBS? One is sensory thalamic DBS. So you put a DBS in VC, nucleus ventralis caudalis, or the sensory nucleus of thalamus. CL DBS, you put a DBS lead in CL, but you put bilateral CL leads, because modulating unilateral CL does not help. As you can see, this is one of our patient who has a VC lead and a CL lead on one side and only CL lead on the other side. So contralateral side of pain, you put a VC lead, and then you put CL leads on both sides. The next one is PAG, PVG, periaqueductal gray, ventricular gray. Periaqueductal gray is a very good target, but what it does, it releases endorphin. That's the source of internal release of endorphin. So it's very good in musculoskeletal pain. I done DBS for intractable back pain. I done DBS for intractable ankle pain in a ballerina where nothing else was working. But that was not neuropathic pain. That was just musculoskeletal pain. Nucleus accumbens DBS, this is a very good target, and this can be used in thalamic pain syndrome, because in thalamic pain syndrome, the substrate, the sensory nucleus of thalamus, CL, is already stroked out. So you cannot put a lead there. So you can go to nucleus accumbens and take care of the affective component of the pain. Posterior hypothalamic DBS, we just done one DBS, and that was for cluster headache. It's complicated. You cannot measure the responses. Programming is, I mean, we didn't have the directional leads then, but programming was awful. Rather than doing a posterior hypothalamic DBS, I will rather do SPG blocks or SPG stimulator, or a combination of supra and infraorbital stimulator and occipital nerve stimulator for cluster headaches. So sensory thalamus, basically when you put the lead in the sensory thalamus, you make sure that the last target, the last contact is at the bottom of the VC, in the middle of the VC. So bottom of the VC is much more lower than the bottom of the VIM, at least 4 millimeters below the bottom of the VIM. So your contact 0 goes down to the middle. So you generally target 2 millimeter in front of PC, and then climb back. And thalamus has such a beautiful somatotopy that if you have face pain, you can just put in a face area. The only problem in this is programming is very difficult, because even slight increase in current and patient will feel it. We've done some isolated VC DBS, and we had a programming nurse. She was a mid-level practitioner, and she always used to check the impedances before doing the programming. And pain patients, I will program myself, but when once went to her, she checked the current, and while the machine ramped up to 3 volts and the patient jumped and started clawing at her, it was so much of pain. So normally VC DBS 0.51 is good with a very low rate. We go to like 30 or 35, maximum 50. And these give good benefit, only they don't last long, and that's why you have to attach CL to both of them, either alone or with VC. It modulates the affective pathway. So what you are doing now is VC is your standard lateral pathway and CL is your medial affective pathway. So when you are modulating both pathways, you get effective pain control. 6 millimeter from third ventricle, 2 behind PC and at ACPC. So again, 3 leads. Most of these patients that we did had 3 leads. And we use Morell's Atlas, and this is the posterior limb of the CL. This was generally our trajectory. CL is a tall nucleus, so, and it kind of fires at like 4 hertz. No background, so it's not very easy to find out using MER. These were some of our earlier patients, 7 patients that we did about 21 years ago, 25 years ago, in 2001 or so. And these are the durations of follow-up, 23 years to 17 years. These people still call me. 2 we had to explant because it was not working in 1, and second needed some kind of procedure. 3 we have reasonable benefits. 2 are completely pain-free even after 23 years. Both were face pain, atypical face pain. Anesthesia dolorosa responds beautifully to DBS. And these are the some of the follow-ups. This is a VAS. And these were the follow-up in the immediate post-op period. What's important to remember is pulse width of 60. That time 60 was the limit, but now we can even go down on it. So we can go down to 30. Amplitude of ipsilateral CL is half in contralateral. So the ipsilateral CL should be at, if contralateral CL is at 3, ipsilateral should be at 1.5. Rate of 25-30 is the best tolerated, and it gives a feeling of warmth. There are so many things that happen. No one knows intralaminar nuclei of thalamus, what they do. They make you more aware, they improve your sleep. Some patients told us they had extrasensory perceptions. Lot of things. Some of the things I cannot talk in front of people, but they did lot of changes. This intralaminar nuclei. Higher rates will worsen the pain. Even in CL, if you increase the rate, the pain will get worse. Higher pursuit will cause sensory side effects. Deeper cathodes that go below ACPC line can cause imbalance because that's the area somewhere cerebellar fibers, dentatorubrocerebellar tract comes. Anterior and medial contacts produce dystonic activity because you are now stimulating CMPF. Nucleus accumbens DBS, this was one of our NIH grant RO1 with Andre Machado, and I was a co-PI. And we put in nucleus accumbens in the thalamic stroke syndrome patients. The target is 7 millimeter lateral to midline, 2 millimeter in front of AC, and 4 millimeter below ACPC. So you want one contact at least in the deeper to the ACPC band. This was published in Annals of Neurology. The benefit in the pain was not very much, but improvement in the quality of living was statistically significant. So patients had pain, but they did not care for them. PAG again works well, but as I said, it works because of endogenous endorphin secretions. 2 millimeters from wall of third, 2 to 4 millimeter behind PC, and up to the upper margin of superior colliculus. Posterior hypothalamic DBS, very complex to program. And this is one of our paper we are writing, 21-year follow-up of 50 patients of pain DBS. So this is the most recent after 21 years. Motor cortex stimulation, we'll have another talk for this. Thank you very much.
Thank you, sir. I think we have 2 minutes more, so we can take one question from the audience.
Thank you.
So my question was that we use microtone recording along with radio frequency ablation for pain, commonly at our center. So I want to know, I know it's difficult, but still, for discharges, what nuances do you use for targeting CLP and PAG?
I mean, MER doesn't help very much. CL targeting is very easy. You go anatomically ACPC and you will be in CL. And CL is a tall nucleus. And the nuclei around CL, if you look at them, so most of I cannot. But most of those things around CL are either MD, mediodorsal nucleus, or pulvinar. So if you are not too lateral, you can safely go ahead and make a lesion. Actually, Jam Manod has been doing CL thalamotomy, RF thalamotomy for now almost 30 years and he has excellent results. But if you really want to do, use MRGFUS. HIFU is the best thing for this kind of thalamotomies. PAG also, nothing significant area around. As long as you are okay with your ACPC target, you can safely make a lesion. There should not be any issue. The only issue can, even in nucleus accumbens, you don't have to go to nucleus accumbens. You make a lesion in anterior inferior capsule, internal capsule, or 4 millimeters below the ventral striatum, you can still get the same benefits. All these pain targets, MER is not very useful.
What I try to do is that try and go search the bottom of the thalamus,
and then come 1 to 2 millimeters above it, which is the bottom, should be the bottom of CLP, and then give macro stimulation and look for.
Use Morell's Atlas, because SW Atlas does not really give you very good idea of where CL is. CL is much more medial, much more posterior, very medial and posterior.
Yes.
So,
Thank you, sir. Yeah.
thank you. Okay, so hopefully you haven't got bored listening to me. So this is the talk which actually is a misnomer. It's not a motor cortex stimulation. We'll come to that, but it's called motor cortex stimulation. So we're going to talk about indications, techniques, outcomes, current evidence. So why motor cortex stimulation of pain? I mean, anyone who knows a little bit of basic neurology would think, why would you stimulate a motor cortex for pain? Motor cortex has no role to play in pain. And but what we are stimulating is not motor cortex. We're basically stimulating central sulcus. This should be called central sulcus stimulation than motor cortex stimulation. So central sulcus has this pils deep passage. These are the interconnectomes that are seen in every sulcus. And this pils deep passage in the central sulcus. Now there is this concept of somatocognitive connectomes. So if you look at the somatocognitive connectome of the central sulcus, it goes from midbrain to forebrain. And most of the cognitive areas, cingulate gyrus, posterior midbrain, and dorsolateral prefrontal cortex, and also frontal forebrain bottom. So this somatocognitive connectome, which is exclusive to the central sulcus gray matter, is what we are stimulating. And again, so we are taking care of not the localized sensory component of the pain. We are taking care of affective component of the pain for motor cortex stimulation. What are the indications? Neuropathic pain, yes. Most of our indications, we done motor cortex stimulation in variety of conditions, except for leg pain, because leg is on the medial side and we were not strong enough to put in lead on the medial aspect of the hemisphere. But otherwise, we've done it for a variety of things. Mostly deafferentation pain, because deafferentation pain needs an alternative pathway to be stimulated. The deafferentation pain is there because sensory pathway is damaged. And if you stimulate a damaged pathway, it's not going to result into anything. So for deafferentation pain, motor cortex stimulation is one of the good options. Neuropathic pain, also motor cortex stimulation helps. We've done it for facial neuropathic pain, atypical face pain, post-stroke central pain, thalamic pain, brachial plexus avulsion pain, phantom limb pain, post-herpetic neuralgias, pain coming out of Wallenberg syndrome. Now, lateral medullary syndrome giving pain is very, very rare, but we had a patient. So we did that. CRPS, multiple sclerosis pain, if the disease is not progressive, stable disease, then we can do that because they do need MRI scans all the time. Patient selection, intractable pain, that is the one thing. All other criteria for chronic pain intervention apply to this. Better if it is localized, because motor cortex has localized areas. And so if we are going to put a lead across the motor cortex, you cannot put more than 2 leads. So the area has to be really small. So if there is a hemi body pain, you probably would not do a motor cortex stimulation. So better if it is localized. Upper body pain is more responsive and of course technically easy. I've seen a patient where someone had slid the lead on the parasagittal side, but we never done it. Neuropsychological clearance is a must. Imaging to rule out any damage to the motor cortex or the central sulcus. And these are just various patient characteristics. Are there any preoperative predictors? Now with TMS coming into picture, a lot of people used to ask us, do you want to do TMS to see if there is any benefit? And yes, TMS is a good positive predictor. So with TMS, if the pain goes down, then with motor cortex stimulation, there is a good chance that you will get pain relief. But if TMS is not effective, that does not necessarily rule out that motor cortex stimulation will not help. Preoperative workup, we did stereotactic MRI scan, stereo CT, bold fMRI with DTI to localize the area of motor cortex. Anesthesia, local general, mostly we did under general anesthesia. And they use the specialized anesthetics where you can actually stimulate the cortex and see the responses using remifentanil and dexmed. So intraoperative monitoring was SSEP, cortical grade, cortical stimulator. Procedure stages were implant of the lead. We did an externalized trial for 7 days, and if patient had benefit, we internalized the leads. If no benefit, opened up the craniotomy, took out the leads, and if there was good benefit, we internalized them, then we did the programming. There are various techniques of doing it. The Italian group, I think for Zani's group, used 2 burr holes and then just slides a lead from one burr hole and pulls it out from another burr hole. Epidural. We always did epidural. Intradural, Jamie Henderson used to do intradural stimulation. Somehow we thought that was too invasive, and the motor thresholds go down significantly. The seizure threshold, we had to check the seizure threshold while stimulating. So what we basically did is we did craniotomy. We first localized the area, face area. According to the area, we did the craniotomy. So this was one of the, I think, this was a hand pain, hand deafferentation pain patient, and under general anesthesia. Linear incision, we had already marked her area of hand on the fMRI scan, and then marked it real time. And we used to do a craniotomy. Some people do it through the burr hole, as I showed you, but we used to do a craniotomy and then put a cortical grade. Now, after putting the cortical grade, you got to look for phase reversal. Phase reversal is this N20, P20 diversion that you see that will tell you where your central sulcus is. So this and this is the phase reversal. This and this is the phase reversal. This and this is the phase reversal. So you come to know that between the contact 4 and 5, between the contact 8 and 9, and between the contact 12 and 13 on that cortical grade is your central sulcus. So you mark those between those contacts. So you actually get a map of central sulcus. And at the same time, once you map your central sulcus, you also do individual stimulation through the cortical grade to find out which is your hand area if you want to put in hand area, which is your face area if you want to put it in the face area. And then we used to use the specify leads. Now those leads are not available anymore. Those were spinal cord stimulation lead. 4 contact paddle lead. Now those 4 contact paddle leads are gone. Medtronic has stopped producing them. I haven't done a motor cortex stimulation since they stopped producing them, but those leads were very nice. We will put 2 contacts on the motor side, 2 contacts on the sensory side. So 2 contacts anterior to the motor central sulcus, 2 contacts posterior to the central sulcus, and 2 specified leads side by side. So there used to be like that. So that was our area of hand, and central sulcus was probably somewhere here. So 2 contacts back, 2 contacts front. These are 2 contacts back, 2 contacts front. And then you bring the wires out from the craniotomy. This is how the x-rays look. You fix the craniotomy, and the wires are attached to extension, and the extensions are coming out. And then you keep the patient in hospital. You choose the contact which are across the central line. So you can choose the one most distal or the closer contact. A tighter stimulation is better because it goes deep in the central sulcus, but sometimes you can use a wider stimulation. So always bipolar, go from one to another. What we have found out that if your active contact is on the motor side and anodal contact is on the sensory side, you get better benefits. And the reason for that is probably the that plis deep passage, the interconnectome is more on the motor wall of the central sulcus. So you put the active cathode on the motor side and anode on the sensory side, and then you start stimulating. Before start stimulating, you have to look for seizure threshold. Too much stimulation will give seizures. So we used to put EMGs to look for seizure threshold. And we used to check the seizure threshold sitting up, lying down, standing up, because it changes, because brain changes, CSF changes. These are epidural stimulation. And then you go 2/3 of the seizure threshold. You can cycle the stim. Programming parameters are generally low frequency, medium pulse widths. You don't need more than 1.5. These are not perceptible. The patient doesn't perceive it. Bipolar stimulation with cathodes or motor cortex, anodes or sensory cortex. Cycling helps quite a bit. If there is more than 50% reduction, we'll do the stage 2. If not, we will not do it. Benefits and complications, we have series of about 45-50 patients, I think. We've seen one infection, but nothing major. And there are a lot of other patients also. What's the future? Maybe non-invasive, maybe better leads, maybe nanotechnology, optogenetics. Optogenetics is very useful. We've done dog studies in which what we did was the dogs with depression, we took out the bone in the dorsolateral prefrontal cortex and put a LED light inside the bone and put the bone back, and the depression score started improving. Do you know, everything inside our body is dark. There is no light inside our body. Light is all outside. There is no light inside the brain. So you just put light on the frontal cortex and the depression will get better. So something like that. Maybe I'm just talking about sci-fi, but something like that will come in future. Thank you.
Very interesting lecture, Milind. Any questions or comments, Girish?
Generally the enthusiasm for motor cortex stimulation seems to have died down. What's your view? Do you think, are you still a believer in it, or?
Anesthesia dolorosa. You've got no other thing you can do. Because anesthesia dolorosa, I used to do peripheral nerve stimulation. Anesthesia dolorosa, that also does not work. So a focal deafferentation pain. Focal deafferentation pain doesn't respond very well, or post-stroke pain doesn't respond very well to spinal cord stimulation. And these face pain patients with anesthesia dolorosa, I had a patient who had 23 surgeries, like 6 times microvascular decompression. His face was completely numb but severely in pain. Got away, completely got better, and it's now many years. Mark DiGiacomo, he's now he won an election in New York last week. But yeah, in selected indications, I think motor cortex stimulation is still a very neat, a very brainy surgery. But there are a lot of other options for a lot of other things. So I will not do it for neuropathic pain. I'll just do it for focal deafferentation pain, either face or upper limb.
I think we have asked the question, but we keep forgetting in the hierarchy of the procedure. Where would you put motor cortex amongst the other procedures, like you said, spinal cord, peripheral nerve stimulation? You have a pain. Would you, because it appears a very elegant procedure, so would you try it upfront or only after you have tried peripheral nerve stimulation, as you said, or you tried something else?
I'll put it on the side and not in the hierarchy at all.
Okay.
In the standard hierarchy, it doesn't count.
Okay.
So it just only for a selected indication, anesthesia dolorosa,
Right.
or severe deafferentation pain which has not responded to cervical spinal cord stimulation. Apart from that, I would not really do a motor cortex stimulation.
So for the patients who have failed spinal cord stimulation, then we can go higher up.
We can, but yeah, the only beauty of motor cortex stimulation is it is targeting a different pathway.
Correct.
It's a completely different pathway.
But as we all understand, spinal cord stimulation is also acting on the brain.
It is also acting on the brain, but it's decoupling the somatosensory and limbic network. And this is just augmenting the affective network. So, yeah, I mean, you're right. In a sense, everything acts on the same pathway, but this exclusively acts on that pathway. In spinal cord stimulation, there is some role of gait, but neuromatrix theory, basically neuromatrix is neuromatrix. Gait control theory, I don't believe so much for chronic pain, because chronic pain cannot be so simple to close a gate. It has to be the whole brain. It's like dementia. So affective component, spinal cord stimulator also. But motor cortex stimulation, just like your trigeminal brace surgeries, not everyone should do it, and it's not needed for every patient. So motor cortex stimulation is like that. I think this talk should be given by Edo, but I'm going to give it. So this is a new tool which is very much in demand nowadays, and people think this is going to replace everything, DBS and all those things. But we got our HIFU machine in 2019, and I used it for pain and movement disorder both. One thing which is really unique about this machine is you cannot harm a patient. It's very difficult to harm a patient with HIFU. I mean, you got to be really, I mean, machine itself has checks that you cannot go beyond a certain point. And HIFU is so safe, and you can go to any part of the brain. So that's another thing. I mean, nowadays you can make a lesion, you can start with PTT, go to STN. So you can make the lesions in a line. Like for CL, you can make the lesions one above other. You can curve the lesion. You can change the sizes of the lesion. And with LOFU, that's a low frequency ultrasound, you can just cause neuromodulation. There is not even destruction. So I think this tool is there to stay. for pain especially, it is there to stay. It's a very good tool. It's very stealthy. You go in and out of the brain without causing any harm, and the patient goes home within 2 hours. So I think it's a very good tool. Lesioning procedures. These are the cingulotomies we used to do. We always did 3 lesions, 1, 2, 3, 1, 2, 3. So 9 lesions on one side, 9 lesions on other side. Very destructive procedures. Again, coming back to Jamanud, Jamanud was the one who first described thalamocortical dysrhythmias, and he was one of the first one to even do the CL thalamotomies using HIFU. So, what are the other modalities? John Reggie has given a very nice paper on this, different modalities, RF, gamma knife, laser, what are the pros and what are the cons, and the same thing with HIFU. So there are various modalities available to make lesions for chronic pain. But HIFU is by and far looks like the safest modality right now. So what is HIFU? You all probably know, but I thought I'll put in few slides about it. It was developed by Insight Tech in Israel, and it was first used for soft tissue fibroids and soft tissue malignancies. And then they started using it for intracranial lesions, to make lesions intracranially. It's MR guided, and you can actually have a real-time MR thermometry while doing the sonication. There is a helmet, and then there is a cap on the head which is filled with water bath. So the temperature at the skin should not rise and you should not get skin burns. You have to shave all the hair. I think they are now working on getting a newer version where you don't have to shave the hair. But right now you have to shave the hair. I think there are total 1800 sources. And depending on the SAR of the skull, some of the sources can go in, some of the sources cannot go in. So I think you need at least minimum of 800. We've done cases like 160 sources also, but that just takes time. So the patient gets on the MRI and this goes around their head, and the patient goes in, and then you can do a real-time MRI. This is another picture. So that's the helmet that goes on the head. You go inside, you can do a real-time MRI to make your target, and then you can look at how many sources you are able to get, and then you can start your early sonications, low energy sonications, and then see the benefits. And this is beautiful in tremors. I mean, in tremors, if I have a choice, I would do only HIFU rather than doing a DBS. And in elderly PD patients, again, HIFU is the one I'll do. Young onset PD, I will not do it. And chronic pain, definitely intracranial intervention, if I have to do, I'll use a HIFU. So this is what the MR thermometry shows, how the temperature goes up and how that graph goes down. If there is a cavitation or something, that can also be seen here. You can use tractography also to target in HIFU, and that gives accuracy in movement disorders as well as pain, both. This was NEGM. Jeff Elias was the first one to start this in US, and this is his trial, and it was published in NEGM, which shows significant improvement in tremor with very little or no complications. What about the use in pain? So as I said, John Monod started using it in pain, And this was his article published in 23. He has a new article with 120 patients now. This is 63 interventions. And this is what he shows the lesion. So you can make the lesion along the posterior limb of CL, 1, 2, 3. So he actually makes multiple lesions now. Even up to 12 lesions he can make. So these are the coordinates that he chooses to make the lesions for CL thalamotomies. And he has one of the best results for CL thalamotomies. This is his Kaplan-Meier graph. The pain comes down almost to zero in all of his patients. So all the p-values here are really significant. So extremely good result. And these are complex pain patients who are referred to him from all over the world. These are not simple chronic pain patients. So HIFU CL thalamotomy really works. What are the other possible targets for chronic pain? Intracranially, spinally, you can do probably midline myelotomies using HIFU if you can find out its use in spine. Musculoskeletal, some people have started using it in bony metastasis and arthritis. So this is what for pain you can do HIFU. HIFU can probably be used in insula. Insula is still unexplored target. Insula is a target which is a very complex target, and you wouldn't want. People tried to put DBS in insula, but did not help very much for fear disorders and chronic pain. So with HIFU, you can make actual lesions in insula. You can also go to brainstem target like locus coeruleus. You can make lesions there. So, so all these, which are parts of the somatosensory processing of pain pathway, you can make lesions. And as I said, that's the beauty of HIFU. And I don't know if one modality is better than other. I think all modalities have their pluses and minuses. But with HIFU, having a complication, having a bleeding is very, 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 very extremely rare. And you can make lesions for gamma knife. You have to have shots. And but in HIFU, your lesions can be stacked one above other. You can give them U-shaped, you can give them X-shape, whatever shape you want to give with multiple lesions. So again, as I said, this is a lovely tool with sensitive touch, flexible, stealthy, and can reach in the nooks and crannies of the brain. And that's why I think in future, when it comes to managing pain with intracranial interventions, probably HIFU will be much more important once it's freely available. And it's a one-time thing. There are no implants. So I think not now. The machines are still not there, and they're still very expensive in India. But as the machines become more common, Dr. Razai's team in RNI is working on small portable HIFU machines. You don't have to go in MRI scan. You can put in a frame and attach the machine to the frame, and you already have targets, and you give the order, and you can do it in OT table, and patient still walks out within 2 hours. So I think once the machines of that time come, this might be one of the primary modality of pain treatment. This is probably slightly more invasive than TMS when it comes to actual the settings and going home and all those things. But you can reach very deep in the brain. I mean, out of all the HIFUs I've only seen one small bleeding, and that too in low frequency ultrasound, not in high frequency ultrasound. I haven't seen a single bleeding in high frequency ultrasound. But CL thalamotomy procedure We are doing anterior capsule lesions with HIFU in OCD, not so much in pain, but we can do that in pain also. And in other targets of pain, whatever brain targets of pain, we put in DBS or do RF lesioning, subcortic tractotomies, or nucleus accumbens. So all these can be basically reached by high frequency ultrasound without incisions, without hospital stays. So I think this is a machine of the future. Thank you.
To Milind, very nice talk. My question is, half a century back we were using RF lesioning. Then came the deep brain stimulation saying that it is non-destructive, and that was the main USP. Now after that whole cycle, we have come back to destructive lesioning. And now we all thought that is industry driven, but now we have you as a major proponent of HIFU. So you said in elderly patients, those with essential tremors, you would actually prefer HIFU over deep brain stimulation. So why is that?
See, permanency is not a curse always. Permanency is sometimes a boon because you have a permanent lesion and you don't have to see your doctor any time again in your life. So that's not bad. I mean, having a DBS system coming every 3 months for programming, checking the batteries, charging it twice a week, worrying about it. So why not just to make a proper lesion, because this is going to be for the rest of their life, and especially in essential tremor the symptom complex is not going to evolve like it evolves in Parkinson's. You have to make adjustments in DBS. That is not going to happen. That's why a young Parkinson's patient, I would still do a DBS because his symptoms are going to progress in a certain way. But in elderly patients, 65, 70, we know it's not going to evolve. Even if it evolves, it's going to evolve into non-treatable motor or non-motor symptoms of Parkinson's. So do it one time, let him go home, and don't have to come back again. And I think this third cycle keeps on changing. I think this is becoming popular, or gamma knife is becoming popular because of the perceived non-invasiveness. It's not non-invasive, but it's perceived as non-invasive. So a lot of people think if I'm going home in 2 hours without tremor, what's wrong in it? It's like always some of my patients ask, I said, well, this is there for last 10 years. What will happen after 10 years? I said, I don't know. But this is like angioplasty and CABG. So you do a CABG, you're good for another 40, 50 years bypass. You do angioplasty, stent might get blocked after 10, 12 years, might not. But it's significantly non-invasive. So if you want to take that course, take that course. Non-invasiveness is a big plus, and permanency is a plus in certain conditions, certain age groups, certain symptoms.
Agreed. So another thing which I had in my mind was, what I read was the disposables for HIFU are very expensive, because that water bath is a disposable. The whole thing is a disposable and costs more than 1 or 2 lakhs. So I just want to know, is that correct?
Yeah, that's correct. But there are things the foundation is trying to give it at a lower price. The price of HIFU disposables is not driving the price. Price of HIFU in India is driven because of the investments hospitals have made in it. It's expensive machine. They got to take the money out. So I think if there are 10 HIFUs, the price will come down significantly.
But for a government institution, it is the consumer which create a problem.
Right.
Because the upfront capital cost we can give very easily, but and we can even provide free to the patient once they have the capital. Like gamma knife, we can give it. But it is the consumer which create a hurdle for day-to-day use in these patients, because most of them are poor. Then we have to arrange the consumer.
I personally, I mean, I'm not an expert, but I personally don't see why that silicon cap has to be disposable. It can be reused.
Yes.
You can just keep that, and as long as it fits tight and water doesn't leak, can be reused.
Yeah, thank you for the talk. I don't know how the economic model works here, but in England, if you do sort of 10 or 20 cases, you can recover all the costs back. So it's almost like cost neutral there, but I don't know how it works here. The only disadvantage of HIFU is if it's very superficial target, it's very difficult to do that.
Correct.
And the second thing is, although people have done staged bilateral thalamotomy for tremor, you still have a high risk of speech disturbance. So it's still, generally indicated for unilateral thalamotomy. So if a patient has bilateral essential tremor, you can still do one side. I would not do both sides. And then talking on Deepak's this one, there's certainly a resurgence of interest in lesioning procedure despite DBS. Certainly, both RFA and the gamma knife and now the ultrasound. I think there's still a role for lesioning procedures, especially for elderly patients.
It got recently approved for bilateral thalamotomies by FDA because the risk is very, very small. And secondly, you can actually test the speech on table by doing low frequency, low intensity sonication to see if speech changes. And if it doesn't, then after making a lesion, chance of speech going away is very, 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 very small. So it got FDA approved for bilateral thalamotomies in US. And this is, you're right. If your target is too lateral or too close to the surface, you cannot get all the sources there. So yes, I mean, doing cingulotomy might be difficult using HIFU. But most of the other targets are central thalamic targets, so it should not be a problem.
So just a comment on the overview of lesioning. So I've been doing it for more than 2 years and 50 plus cases in movement disorders. And sir, RF ablation is, lesioning in general is a very, very, underutilized and underrated actually. And of course, our industry and everything drives it. But in my opinion, the patients are quite happy. Most of them don't complain for the second side because most of the fine work can be done by one hand. So, they're not so unhappy. Even in Parkinson's disease, the results have lasted for at least 2 years. Especially when with a significant asymmetry of either dyskinesia or the rest tremors, which generally is, but high asymmetry, it works, much better.
I completely agree. I think RF should be done more. And once you start doing this more and more, you will start making lesion sizes bigger. So it will last even more than 2 years. It will, I think initially we are prone to make lesion sizes smaller. And then after few years, I can add another lesion 2 millimeter up and nothing will happen. So in that case, that will probably even last longer. So RF, for India, RF is great. Dr. Dodamani, where is he? He's gone. But he had this dystonic storm patient last month and wasn't going away, Wilson's disease. And he did a unilateral palidotomy and the dystonic storm went away. So the patient came off the ventilator. So that's the beauty of palidotomy. You can do it very quickly if you have the RF thing, straight haptic frame, MER setup in your own hospital. You can do it without asking for implants.
Right. And sir, PTT I think is even a more game-changing thing than palidotomy, which is a more dispersed target, and PTT is quite, compact.
PTT is very good. We used to think that VOA, VOP is good target if you have, and they're still good targets, but PTT is much better than that. And again, with HIFU, you can do along the PTT lesions, going all the way up to the base of thalamus.
So you can do multiple. Yes.
So you can get so much benefit in echinacea and rigidity.
Right. So, and one last comment about bilaterality. So what we do generally is one-sided PTT, and when it is required for the next side, we do palidotomy. So non-corresponding targets, I think, work very well for either Parkinson or dystonias, and
rather
such.
than bilateral.
Rather than same structure.
Palidotomy is if
Yes,
you
sir.
do one PTT in one palidotomy, or even both PTTs.
Even
that's
both PTTs, sir. Yes,
much
sir.
more safer. much
So we've
more
done
safer.
5 both PTTs and quite okay, manageable. No, not much side effects
Good.
in general. Yeah.
Thank you, sir. Very
Thank you.
fascinating talk.
I'll try to run fast through the talk, but I might go over time a little bit because this is one of the subjects I love. I started doing peripheral nerve stimulation in 2003 when no one else was doing it. Konstantin Slavin and me were the first one who published on PNS. So I'm going to talk about occipital nerve stimulation, but I'm going to cover PNS also. So peripheral neuromodulation basically is not only about pain. It's about functional electrical stimulation. We did FES, we put in the bions on the nerves to make the nerves move. It's a bladder bowel function, sacral nerve stimulation, VNS, motor stimulation, phrenic nerve stimulators, hypoglossal nerve stimulations, autonomic stimulation. We designed autonomic stimulators for renal stimulation and bronchial stimulation for asthma and hypertension. So I put in peripheral nerve stimulators everywhere in the body. My nurse had a chart of a humanoid, and whenever I put a PNS, she will put a stick on it, that little hat pin, and I was full of hat pins. So everywhere we put in peripheral nerve stimulation, perirectal pain, testicular pain, inframammary pain, everywhere, and it works pretty much everywhere. It works. How does it work? Does it block the nerve? No chance, because Dominic Duran, Nilay Bhadra, and we did the experiments where we did muscle nerve preparation, tried to block it. To block a myelinated nerve, you need 4000 hertz, 4 kilohertz of energy. None of these commercial things can provide it, and if it provides, it will burn the nerve, so it will be neurotomy. So it doesn't block the nerve. Then what does it do? Probably closes the gate at that level, at the nerve level. More than that, it works centrally. Central neuromodulation in chronic migraines. We published a paper, and this was another paper. This was occipital nerve stimulation paper, where they've shown that patients who had good benefit, all their pain areas, nociceptive areas were deactivated. And this was one of our RSD patient where we did the peripheral stimulation. This was when the stimulator was off, and this was when the stimulator was on. Look at the nucleus accumbens. The nucleus accumbens is completely deactivated. So it works centrally. It doesn't work peripherally. And that's why the objection was, should we call it peripheral nerve stimulation? So Konstantin Slavin and we had published that CNS volume. We started calling it peripheral nerve field stimulation. You are actually not stimulating the nerve. You are stimulating the skin or the dermatome supplied by that nerve. So that dermatome closes the gate, if it closes the gate, because you get vibrotactile, just like TENS machine does. But TENS machine does to the surface. What we are doing is going below the subcutaneous area and catching the nerves coming from vibrotactile receptors. So we started calling it peripheral field nerve stimulation, and we did another experiment in occipital nerve stimulation. I'll tell you about that. So this is a simple solution for a very complex problem. These localized focal pain areas are very, very complex problem. And these pains are rarely over a defined nerve. Sometimes in hernia, if they tie ilioinguinal nerve, you will have that in ilioinguinal nerve distribution. But otherwise, they are kind of in general distribution, like around the ankle, around the knee. So first few we did, we put in the paddle leads. That time these specify leads were available with 4 contacts. One contact, one lead above other over the nerve, stitched it. And Amit was then my fellow, so we published also this. But this was too cumbersome, too big a procedure. So we started just putting in the leads in the vicinity of the pain, below the skin. And we have these 1700 patients, 15 patients with paddle sandwich leads. Average duration 9 years, range from 1 to 27 years. Number of surgeries in past, average 2.5, range 0 to 11. And these are the different locations that we have done. Maximum is occipital neuralgia, supraorbital stim for migraines, complex craniofacial pain, low back pain, mid-thoracic pain, neck pain, neuralgia paraesthetica, inguinal neuralgias, peroneal nerve region pain, pudendal perineal pain, pudendal neuropathy also it works very well, arm pain, shoulder pain, hand pain, post-herpetic neuralgias, post-thoracotomy pain, even post-craniotomy pain, abdominal pain. For pancreatic pain we had done that. So occipital nerve stimulation, the main indications were occipital neuralgia, episodic migraines, continuous migraines, cervicogenic headaches, cluster headaches, otalgia. Sometimes the otalgia also responded. We had to put one lead in the front and one occipital lead. Fibromyalgia, all these responded fairly good. Now, when I say good, well, beforehand we used to tell the patient before the trial 50% will get benefit, and benefit will be around 50%. And most of our patient, I mean, on an average, we got about 60% or 70% trial to conversion ratio, trial to implant conversion ratio, because our neuropsychologist was very strict and she wouldn't let any patient pass. So, most of them had more than 60% benefit. We always did surgery in 2 stages: trial placement, 5 to 12 days trial, then internalize, and then pain medicine, then programming, and then pain medicine reduction. And this is a general cohort. We had published of around 800 patients. Old slide. This was I think 2012 or 13. So after 10 years, we still had a good benefit in all those patients. Location-wise, face pain seems to respond the best. Trigeminal, post-trigeminal, post-intervention trigeminal neuropathic pain responded best to peripheral stimulation. In general, craniofacial pain is not different than other pains. It still responds the same, slightly better, but not statistically significant. Duration of pain also not very statistically significant, though longer the pain lasts, there is less reduction in the pain scores. Gender also not significantly responsive difference. Complications, we had migrations in 2 in all these patients, infections in 3, erosions in 3, loss of efficacy leading to removal in 2. So what we did to optimize the outcome, especially in ONS, just going to talk about ONS, patient selection. In ONS, in occipital neuralgias, unilateral occipital neuralgia will always respond better than bilateral occipital neuralgia. If it's a migraine, then just don't put only occipital stimulation. You need a C2 stimulation. Along with that, you need a trigeminal stimulation. So 2 supraorbital leads, I used to go from here, 1 supraorbital, 2nd supraorbital, 1 occipital, 2nd occipital. If you get both the systems stimulated, the migraines will go away. The migraines respond very, very well. Neuropsychology, of course, needs to be clean. Lead location in occipital neuralgia, there are a lot of people think lot of things. There are 9 ways to skin a cat. You can put a lead horizontal, or you can put 2 leads going that way, or you can put 2 leads going that way. The only thing you need to remember is your leads need to be above C2. That's where the occipital nerve comes out. So above C2, your leads need to be, and you need to be very close to the midline, because the midline contacts are the best contacts. Doesn't matter if you stimulate laterally, the stimulation will go in your ear, but your migraines won't go away. Unless you stimulate in the midline, the migraines or headaches or occipital neuralgia will not go away. These are some of the pictures. So like I was saying, these both systems need to be stimulated. So 2 occipital leads, 2 supraorbital leads. And these are 2 V2 maxillary leads. And these are just plain simple occipital leads, 1 on either side, 1 on this side. So initially when I used to use C-arm to do this, I'll go from the odontoid process to mastoid on either side. odontoid process to mastoid. So 2 centimeters before the mastoid you stop. So your contact zero remains in the center, and 2/3 of distance to mastoid. Then I just stopped using X-ray also. This was a post craniotomy pain, so we put in leads around the craniotomy site. And this was the lifesaver. This is what made us do all these cases. On-cue tunneler. This is a tunneler for pain buster pumps. Those pumps they put in for post-operative pain control. And this tunneler has a very, very soft tip and has a sheath which you can peel off. And it bends any which way you want. So you want to put it here, you put it, you bend it, you put it. The tip will always remain in subcutaneous plane because it's soft. It's not sharp. Sharp will come near the skin, then the patient will start having burning or will go down, then the patient will not have any benefit. So we used on-cue tunneler. This is just how we used to put the on-cue tunneler through a small incision, lift the skin up, put the tunneler in, put the leads in. This is how we used to mark the area of pain. So rather than focusing on the nerve, we used to focus on the area of pain. We would either bracket the area of the pain if there is a lot of allodynia, sensory loss, or we will put it through the area of pain. And these are some other leads that we have put in various types of peripheral stimulations for neck pain, for central pain, for neck and shoulder pain, for median nerve injury, for non-specific abdominal pain, for post-thoracotomy pain, for again back pain non-operative, and this is post-herpetic neuralgias, and this is post-herniorrhaphy inguinal pain. You put in leads right over the inguinal nerves, the pain goes away completely. Shoulder pain, leg pain. So you have to anchor those leads. Programming is very, very important. The rate cannot be above 40 or 50. Peripheral nerves cannot tolerate rates above 50. If you make the rate 20 or 30, it will be thumping. So thumb, thumb, thumb. At 40 or 50 will be pleasant. If you go to 100, it will start burning. So always peripheral nerve stimulator, 40 or 50 rate. Pulse width 60 or 100. You make the pulse width bigger, you go too near the skin and again it starts burning or pinching. Use minimum number of cathodes. Use large bipolars. Don't put in cathodes. That's why some of the systems like Boston's where there is fractionated current is not good because it creates globulates of currents. We need to have a smooth bipole. And guarded cathode is not useful. You guard the cathode, it will basically drive the stimulation in the skin. It will start burning and pinching. So ONS in general and PNS, as I said, is safe and minimally invasive, has excellent therapeutic benefit, acceptable complications, and can be used for difficult area pain. We used it in perirectal pain in patients with bad pudendal neuralgias where you cannot do anything. We already did the pudendal canal decompression, they still had pain. So in inframammary pain, now how are you going to treat it? You can put in DRGA, but DRGA is too much invasive. And I'm always afraid of DRGA. It doesn't matter what Dr. Dureja says. I'm always very, very afraid to put. This was one of the trial we did, sub-Q stim. Autonomic, this is the one that you were talking about, our company that stopped producing it. And then the idea was to put in stimulating rings in the bronchia, in the trachea, and then stimulate when you have asthma attacks. That way they stimulate the sympathetic and attack goes away. So focal autonomic neuromodulation by peripheral stimulation. Same thing in the kidneys, like patient comes in a shock, you put a stimulating stent, so there is sympatholysis of the kidneys, rest of the body sympathetic tone remains high, but you don't get into acute renal injury. And once they come out of shock, pull it out. So these were some of our patents. And this is a book written by me, Borrowed Pen. It's a poetry book. available on Amazon. So that is my hobby, pain. That's why I do so many pain surgeries. Thank you for listening.